My name is Craig. I'm the new rehab director at Plymouth Bay Orthopedics, and Dr. Leckie asked me to talk at this conference. So I chose to talk about a topic that there's not a ton of research out on, but I feel like we use it a lot in, especially as hand therapy, with talking about different types of splinting materials, style of splinting materials, or style of splints that we make, and why that would be better or worse for our patients. So, disclosure, I have nothing to disclose. Why this topic? Now more than ever, there's more choices for custom fabricated orthosis. Every year, it seems like there's one or two different companies that come out, and they come out with these really cool different materials to make custom splints with. Most of the time, they're kind of junk, and they require you to buy a bunch of extra components to it to make that splint specifically, and they sucker some people into it, but I think overall, they're not that great. But every once in a while, there's a great new company that comes out with a really cool new splinting material. And so I'm that guy at all the hand therapy courses that just kind of, everybody's talking, and I'm in the back room, like playing with all the splinting material, trying to find the newest, coolest one. So I think there's more materials now than ever to look into custom orthosis. More research is also on healing and immobilization times currently available, putting patients in orthosis earlier throughout their healing time. So what does that mean for us? How can we get the best outcome from our time in a splint? I find that the therapists are, another issue I wanted to talk about today was I find that there's a lot of therapists that are still using what they're comfortable with. And I encourage therapists who make an orthosis to try different materials. Just because you learned a certain material, you know, I've been doing it 23 years, so I learned materials 23 years ago. It's a huge jump in the type of materials we have now. So if I still use those materials 23 years ago, am I doing the best for my patients? And then also another reason I wanted to talk about this is a lot of complaints from patients on comfort or restriction of certain materials. The harder a material is, the more restrictive it is, usually the more complaints we get. So how can we make those harder materials softer and more comfortable for them? So I think I have a decision process I go through whenever I have a patient come in, and I find it's really three people I consider. One, we have the MD. What was the diagnosis? What was the surgical procedure? And do they give you a type of orthosis? Most hand surgeons are very specific. Do they want a hand-based splint? Do they want a forearm-based splint? Do they want a finger-based splint? But sometimes they're not. Sometimes it's hand pain. And okay, cool, so what do we do with that? As a therapist, we need to know what materials we are comfortable using. So number one, what we're comfortable with. Number two, available materials at the clinic. A lot of us maybe work at clinics and we have one type of splinting material to use, and we have to make the best of it. So what do we have at the clinic? And then what are your skills with the different types of materials? And then of course is the patient. What are their needs from this orthosis? They need to return to work. Do they have certain hobbies they want to do? Sports, activities of daily living that they can't do with certain types of splints versus others. The age of the patient, also important. How's their skin integrity? Is it super paper thin? Is it nice and hardy? All of that matters. And their activity level. I can make the same exact splint. Excuse me. I can make the same splint. One out of a harder material. One of a slightly, this is even harder material. Super lightweight. Nice and soft. Even softer with a neoprene over the counter. Or one that has, it's a neoprene over the counter, but I have a piece of thermoplastic material inside. Same splint. And I can make it for a plethora of different people. If I have a 86-year-old woman who sits at home most of the time and watches TV and has to watch her, talk shows, Am I gonna do a really hard material like this? Probably not. Probably gonna work on something a little softer, because she's not gonna be doing a lot. But I could have another 86-year-old woman who's super active and is out gardening every day. Well, then my material that I use is gonna be a little different. It's gonna be a little harder, a little bit more restrictive. So don't just cookie cutter, give the same material. So we have the over-the-counter splints, which I have here. I'm just giving like a hand-based thumb spica, for instance. So here's our Comfort Cool splints. Over-the-counter, I'm not getting paid by Comfort Cool, by the way. So don't worry about that. So pros of the over-the-counter splint, they're usually cheaper. They are cheaper. They're made with a softer material for comfort. Those are all great things. Cons, they typically are a poor fit. Nobody is a small, medium, large, or extra large. We all have different components to our hands. Some people have really skinny wrist, really wide MCP areas, and an over-the-counter splint doesn't fit right. Custom fabricated orthosis. Pros, they custom fit to the patient. So perfect, right? They fit absolutely perfect. You can account for all of their deformities. You can account for comfort. They're more restrictive than an over-the-counter splint because the material is a little harder, which would help with healing. Plus, you can customize colors and make it fun and get the patient a part of everything. Cons, really the only con I ever see is the cost. It can be really expensive for patients. Choice two we have a style of splint. Part of this comes from the MD. A lot of times the MD knows exactly what they want, and they'll tell you exactly what they want. I want a forearm-based thumb spica splint, or talking about Dupuytren's release. Sometimes, a Dupuytren's is really easy, like that one in the picture there. Snapped right away, has nice range of motion, no skin tear. Perfect, right? You can get them in a very minimalistic splint. Or you can have a really involved case where tons of work. They had to open them up, clean everything out. They had to go, sometimes I've seen even Dupuytren's releases having all the way down near the carpal tunnel. So maybe we want to include the wrist for a little bit. So now we're talking forearm-based splint. And that's going to help that patient get better faster because they're not going to be irritating as much. So we have forearm-based, hand-based. We also can do volar-based on the underside of the hand. We can do dorsal-based on the back. We can do circumference-based, which the splint would be a splint that, like an ulnar gutter or a radial gutter splint, which goes around the dorsal aspect and the volar aspect of the hand. So there's a lot of choices that we have to make. And decision three, which is kind of the talk tonight, is material. So again, not paid by any of these people, I'm just giving examples here. There are multiple materials on the market with all different characteristics and thicknesses. Orthotic Classic or Preferred, so this material here, it's that kind of classic white, thick, hard, really rubbery material. So when I came out of school 23 years ago, this was kind of like what we made everything out of. Super uncomfortable, but very restrictive. We have Aquaplast, and Aquaplast has multiple colors that you can pick from, which can be fun. They also have multiple thicknesses that you can pick, really, really thin like this one, or a little thicker. So Aquaplast is kind of nice. You can do a bunch with it. What do I say here? Oh, it's great for finger digit splints because it is lightweight, it's thin. You get a big digits finger and you put a big thick material like that, it rubs against the other fingers, it's uncomfortable, they're not going to want to wear it, so you go thinner. NCM or Taylor splints, kind of these guys right here. Again, it's really thick, it's really moldable, it's really nice, and it's a little harder to use as a therapist. We have to kind of practice with this one. This is the one that you leave your thumbprints in, and so we got to be careful with this one, move quickly. I always thought that, those shows like CSI Miami, I always thought like the murderer, you'd find out who it was because of the thumbprint and the splint, Not that, I'm just saying. And then another one would be like casting material, like Delta Cast or Orphic Cast, where we have more of a circumference type of splint. Great for our athletes who are going to be playing football or they're going to be playing hockey and they need something really restrictive and really solid underneath their glove. Speaking of that, case study number one. I wanted to kind of do this. It's got us thinking a little bit. 17-year-old male football player. Diagnoses, he had a fractured scaphoid. For those who don't know what that is, a little scaphoid fracture is a bone in your wrist. Very common for young athletes with pushing injuries, so lacrosse players, football players, hockey players. They were 6 weeks post date of injury, and they're out of the cast. No surgery needed, just in a cast. They get sent to therapy for a custom forearm-based thumb spica orthosis. Thumb spica, for those of you who don't know either, is just it's like one of these. It's a splint that comes around the thumb. IP joint's usually free. You can have a hand-based or forearm-based, which is a longer one. This kid, just a note, this kid's gonna play football. Doesn't matter what the doctor told them, doesn't matter what the therapist told them, they're gonna play football. So, what do we make? What are some of the things that we're thinking about when we go to make a splint? Are we gonna make a thin splint? Probably not, because they're gonna play football. They're gonna hurt themselves again. So we want a nice thick splint. So my rationale, I'd make them a forearm-based thumb spica, IPJ free. I'd make it out of a Delta cast material. I don't know if anybody used Delta cast before. It's a big, thick material. I can pre-pad that material before I make the splint. So all the areas that are bony prominences that might dig into them, it might hurt, I can pre-pad it. So I'm gonna make that splint for them. The ATC, or the athletic trainer, is gonna club that splint. They're gonna soft pad it, and they're gonna allow them to go play sports. The material is very rigid, taking lots of impact while protecting the fracture, holding up during the season. That's the other thing. It's gonna last the whole season long. It's not just gonna break after the first 2 or 3 times. I can pre-pad the orthosis in areas of bony prominences, and I can add to the comfort during use. Case study 2, we have a 15-year-old gymnast, female gymnast. For you hand therapists out there, where would I expect a 15-year-old female gymnast to have pain in their wrist? I would expect it in their ulnar wrist. That's where they always have it. So the ulnar-sided wrist pain from a DRUJ sprain. The mechanism of injury, they were tumbling, did a back handspring, landed about 4 weeks ago, had a lot of pain. It's persisting into a mild to moderate level on the visual analog scale. Note, this gymnast is a competitive gymnast, so she's competing. She has her state final next week. The ATC has been taping her, but it's too restrictive, not letting her go back into extension with tumbling. And per the patient report, what do I make? I don't want any restriction on her wrist right now. I want to keep her DRUJ solid. I want to keep that supported. I want her wrist can be flexion, it can go into extension, that's fine. So I wouldn't make anything. I'd fit her with an over-the-counter wrist widget or a bullseye style splint, which is a distal radial ulnar joint splint that's going to protect her distal radial ulnar joint. It's going to provide support while she's able to do her gymnastics. This will allow her to have nearly full wrist range of motion for tumbling while supporting her DRUJ to decrease her ulnar-sided wrist pain. The material's soft, it's comfortable, and it won't dig into her wrist. If it doesn't do those, if it doesn't dig, she's gonna wear it. The other option is you make her something that restricts her wrist, she's not gonna wear it. And then what are we doing? We're not helping her. We're not helping her get through, because she's gonna do it. So we're gonna make her a splint that she's gonna use. Case study 3, 84-year-old female gardener, like we were talked about earlier, severe first CMC joint arthritis. It's a very severe arthritis, however, she doesn't have a ton of pain with it. It's really only pain with heavy gripping and activities with gardening and using tools, but she's got severe deformities in her thumb. Her CMC joint is jacked up, her MP joint is hyperextended, she looks like hell, but she's out there and she's doing her thing. So what do we make for her? So I would go ahead and make her one of these hand-based splints. I would do a restrictive material, resistive material, like Taylor or NCM, to mold to her deformities. I want to get a good mold on her deformities so that she doesn't have any areas of pain and discomfort. It's going to provide her the support she needs. I'm going to try to get her thumb back into a normal position where she can actually use her tools and she's not hyperextending at her MP joint and causing more of a deformity. That's that's the kind of splint I'm gonna make. It's a drapable material, allowing increased molding over deformities, thus increasing comfort for patient. It's rigid for support, correct deformities, and decrease the pain with use. It's hand-based, allows wrist movement with digging, grasping, guarding tools. Last one, case 4, 45-year-old male construction worker, displaced distal radius fracture, no surgery required. Mechanism of his injury, fell off a ladder, sustained a Colles fracture of distal radius. On the emergency department, they were able to relocate the fracture, cast it for 4 weeks, great bone healing per MD. So 4 weeks, you might think, well, that's a little early to come out of a splint or a cast, but they sent them to us because we're gonna get them in a really solid splint that they're gonna use. So patient is planning on returning to work on a light duty in 2 weeks. What do I make? I'd make a wrist neutral, wrist hand orthosis with a Taylor or NCM material, but I would do it in a circumference style. I would do something that came around the ulnar side and come all the way up to the thumb so that they have resistance into extension and flexion, not just on volar one. Because you put a volar splint on somebody that's gonna use it, only things preventing them from extending is straps, and they're gonna bust through that. So we wanna put them in a nice splint that goes all the way around. And that's gonna help with increasing the healing of the fracture, with the reduction of wrist movement and flexion as well into extension. It's also easy to clean if they're a construction worker versus some of the other materials, which can get kind of funky. Conclusion. As therapists, we need to understand that adapting our orthosis rationale for fabrication and research advances and as new products and materials emerge on the market, we need to use them. We need to critically think about the choices we are making with our orthosis fabrication to allow the best treatment for our patients. And I challenge all of us to constantly be learning new skills in orthosis fabrication, new materials, new styles, and not just be comfortable with using the exact thing we've always done. My references, and thank you.